Hi, welcome to session 4 of Infectious Disease Epidemiology. I'm Dennis Nash, and today's session is focused on public health surveillance, scratching the surface. I say scratching the surface because I teach an entire course on the subject of public health surveillance. So this lecture really will touch only on a few key concepts that are important. Surveillance is incredibly important for monitoring and controlling infectious diseases, which is why we have a lecture on it in the course. But first, just to touch on a few administrative issues. You have your first reaction paper due next week, and it's going to be based on the readings for this week's session for this lecture. Just a reminder to please review the instructions in the syllabus very carefully. Please make sure that you keep the length of the reaction paper to less than 2 single-spaced pages. As a guide, I recommend it be between 1 and 2 pages. Make sure you cite all your sources that you use to inform your writing, including the course readings for this session, and submit it by Blackboard, not by email. And be sure not to include your name on the reaction paper. Blackboard will take care of all the tracking for us. Okay, so we will cover the definition of public health surveillance and surveillance systems, and we'll talk about surveillance system attributes as well. And we'll talk about where surveillance systems get their information, the sources of information for public health surveillance systems. And then we'll talk briefly about surveillance for SARS-CoV-2 in New York. So surveillance is the first step in what's called the public health approach to health promotion and disease control in populations. And it helps us get from answering the question of what is the problem, which is really what surveillance is about, to a place where we can ultimately deploy a public health response that can actually address the problem. So, once we can use surveillance to characterize what the problem is in epidemiologic terms, we can then begin to think about moving on to other steps in the public health approach, including risk factor identification, which is trying to figure out what the causes of the problem are, or the disease, or in our case, the infection. And then once we know the causes, we can begin to think about what some possible interventions might be in order to control or eliminate a particular disease or health problem. And we can test different interventions to identify which strategies work and evaluate them. And then once we know which strategies work, we then think about how we can implement them at scale so that they have the reach to have the impact on population health outcomes. And so there's a whole area of implementation here that is about how do you get from the place of an effective intervention that we know works to do what you want to a place where you can implement it at scale and have the impact at the population level. At that point, I would also argue that there is a sort of feedback loop here. When you are implementing interventions at scale to control a particular public health problem or address a particular public health problem, you can then use surveillance systems to evaluate whether or not it's actually having the desired impact on the population health outcome that you're focused on. So public health surveillance has some very broad purposes that support the ability for public health agencies to achieve their goal, including assessing broadly public health status, defining public health priorities, which we saw with the examples of tracking the causes of death in populations and ranking them as a way of setting health priorities. But of course, it's important to think beyond causes of death, and surveillance gets into disease-specific outcomes and even risk factors. And you can use surveillance to help define public health priorities. It can help target scarce resources in public health in this country and most places in the world. Resources are scarce. There's not enough money to really address all the public health priorities that we need to address. And so surveillance is a way of helping you figure out, well, where are the resources most needed? And then you can target them accordingly, since there's not enough to go around. As I mentioned, you can use surveillance systems and public health surveillance to evaluate programs and also to stimulate research. So let's look at the stated mission of some public health agencies at the local, state, and national level to get a sense of how surveillance, activities like surveillance, would support them. So at the local level, for example, here in New York City, the stated mission of the New York City Department of Health and Mental Hygiene is to protect and promote the health of all New Yorkers. At the state level, the stated mission is we protect and improve and promote the health, productivity, and well-being of all New Yorkers. And at the national level, for example, the CDC, the mission is stated as CDC works 24/7 to protect America from health, safety, and security threats, both foreign and domestic. Whether diseases start at home or abroad, are chronic or acute, curable or preventable, human error or deliberate attack, CDC fights disease and supports communities and citizens to do the same. So if you think about what the charge and the mission of these agencies are, it's about both protection and promotion of health of populations. You can see how very important it is to have information on the health status and disease burden in order to really succeed at achieving these missions, making surveillance really a core function and prerequisite for nearly all of the activities going on in public health agencies. What about globally? So this is the mission statement, or at least a statement that sounds like a mission statement from the World Health Organization, just to give you a sense of how all this fits together. WHO is the directing and coordinating authority for health within the United Nations system. It is responsible for providing leadership on global health matters, shaping the health research agenda, setting norms and standards, and articulating evidence-based policy options, providing technical support to countries, and monitoring and assessing health trends. So again, while it is not working directly with constituent populations the way local health departments do, there is a need for data and surveillance in order to inform and support the success of the agency to achieve its goals. So let's define public health surveillance formally then. So CDC has put forward a very widely accepted definition of public health surveillance, one that I use in my course, and it is as follows. Public health surveillance is the ongoing systematic collection, analysis, and interpretation of health-related data essential to the planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of those data to those responsible for prevention and control, and to other stakeholders, including those who report information on individual cases. So there are a couple of key words in here that I've highlighted: the ongoing systematic collection, analysis, and interpretation of the data, of course. But importantly, if that data just sort of sits in health departments or in public health agencies and doesn't get out to people who need to know, to people who need the information so that they can act on it, the surveillance is really is not useful. In fact, I would argue that it's not really considered surveillance unless it has this dissemination step. But it is also often a weak link of many surveillance systems. So the concept of public health surveillance is embedded into surveillance systems that are usually disease or exposure specific. The surveillance systems today can take many forms. The oldest and most well-established systems are those that monitor the occurrence of communicable diseases through required reporting mechanisms, such as requiring healthcare providers, physicians, laboratories, and hospitals to report that information to the health department on occurring cases or other notifiable events. But they don't just track infectious diseases, and this is a point I want, even though we're in an infectious disease course, I do want to stress and emphasize that more recently established surveillance systems really monitor a broad variety of health conditions. So that can include things like injuries and birth defects and chronic diseases and even health behaviors and risk factors. So, and the other thing that I want to point out is some of these surveillance systems, have to collect the data themselves on reportable events and cases of disease. Others may rely on existing data to serve the goals of a surveillance system. So, for example, some of the systems use vital records and death data. Others use like electronic medical records or hospital discharge data and various national and local surveys, phone surveys or internet-based surveys. So we've defined public health surveillance, but what is a public health surveillance system? Well, it's all those things that go into the definition of public health surveillance, such as data collection, analysis, and dissemination, plus a wide range of other things, such as support services, in order to make the system run. And that includes staff that need to go out and do clinician and laboratory and education about what the surveillance system is, why it's important that they engage in the process of reporting. It means that those staff have to be accessible for receiving the reports and for answering questions. Staff also need to be involved to do data quality assurance and control of the information that is reported from providers and labs. And there needs to be some kind of visible presence in the healthcare community or out in the community representing this surveillance system, disseminating some of the data that comes from it so that you can get the community and other stakeholders to appreciate its value and see how it's being used to improve health and inform policy. And so that means that there needs to be working systems for disseminating alerts and bulletins and recommendations and things that flow from the information that is generated from the surveillance system. And as we said just a few minutes ago, it may or may not be based on notifiable disease or event reporting. It could be a surveillance system that is based on existing data sources that are collected for other purposes, and we'll cover examples of that. So in the US, at least, the concept of public health surveillance doesn't really include the part where there's programmatic implementation in response to the data to prevent and control disease. But it does include this intended link between the activities of surveillance and the public health action that follows from them. And so it's really important that this link be articulated and understood and in place, because surveillance really doesn't have an impact unless there is a direct link to public health action. And that can include things like setting of priorities for programmatic activities, or planning, implementing, and evaluating disease control and prevention activities. So surveillance systems have attributes that can be used to understand their strengths and weaknesses in relation to the goals that they're trying to achieve. For example, imagine a surveillance system for an infectious disease like measles. The goals of the surveillance system might be to rapidly identify and characterize all new cases of measles and to rapidly detect outbreaks of measles. So we can go through some of these attributes here, keeping in mind the goals of this hypothetical measles surveillance system. So intensity, this refers to the extent to which a surveillance system is either active or passive, or somewhere in between, like a hybrid. Active is really the most intense kind of surveillance system you can have. It is intended to really devote staff time and resources to actively go out and look for new cases so that you can capture them in your surveillance system. And so people are actually soliciting case data by designated staff, and it's their job to do the case finding. Passive surveillance, on the other hand, is a less intense kind of a surveillance system, and probably the most common kind of surveillance system, where you have the collection of case data that happens because people who are required to report it sort of voluntarily comply with the reporting process. So physicians and healthcare workers and laboratories are made aware of the fact that they need to report certain information about particular health outcomes or notifiable conditions. And then, you sort of expect them to do that, and you, at the health department, you wait for this information to come to you, as opposed to sort of actively going out there and getting it yourself. It's kind of like a push-pull kind of difference. So what happens in the more intensive kinds of surveillance systems that are active compared to one that is less intensive or passive? So with active case surveillance, you have staff going out, for example, to review emergency department logs, looking for specific kinds of syndromes or injuries. Or in the case of HIV surveillance, they might go to review the rosters of HIV clinics to see if there are individuals that have been newly diagnosed and perhaps not reported or captured in surveillance. They could be routinely querying infection control practitioners to see if there have been new cases diagnosed or identified, or routine queries of laboratories to see if there have been people that have tested positive recently. So in this situation, health department staff are actively looking in these areas to identify new cases of a particular event that's under surveillance. Whereas, as I mentioned, passive surveillance is more like you're relying on providers and laboratories to gather that information and submit it to the health department in some kind of hopefully streamlined system so that the health department can get that information and use it. Sometimes you'll see, as we've been seeing a fair bit with the SARS-CoV-2 pandemic here in New York City and also with measles, when there are cases occurring, you might see the health department put out a broadcast alert that is basically informing people what's going on, usually providers, with regard to a particular health outcome, and maybe reminding them or asking them to report new information or to take extra care to look for all of the cases in their practice and report them. This is called enhanced passive surveillance because it's still not the health department staff going out to the field and looking for cases themselves and bringing that information back into the health department, but it is kind of like stepping up the provider and laboratory reporting process by giving reminders. So as you might expect, the case finding that you get is much more complete in active surveillance compared to passive surveillance. So this was an old example, but it makes the point where they compared an active approach to a passive approach to surveillance for 4 different infectious diseases here. So in the active surveillance mode, they were detecting 140 cases of each of these different infections, whereas with passive surveillance, only 48 cases were detected. And you can see, the active surveillance tended to identify between 40% to 500% more cases than the passive approach. So active surveillance, more intense surveillance, is going to be more complete. And completeness may be very important for you depending on what it is your surveillance system's trying to achieve. In the case of measles, our measles example, we talked about the goals of this particular system is to identify all cases of measles and rapidly detect outbreaks of measles. And so that identification of all cases kind of implies it's a surveillance system that really needs to prioritize completeness. And so perhaps an active surveillance system might be more appropriate for this hypothetical measles example. But as you might also guess, the cost of active surveillance is much more than passive surveillance because you do need more dedicated staff to actually do that work of going out and doing the case finding. And it is mostly an added cost of staff. And so this is a similar, that same study compared the cost of active versus passive surveillance here, and it was about 3 times as much. Another attribute that's important for surveillance systems and infectious disease surveillance as well is the sensitivity of the surveillance system. So we can think of the sensitivity of the surveillance system as the proportion of cases, it relates to completeness, the proportion of cases of a disease or health condition that under surveillance, that occur in the population that are actually detected by the surveillance system itself. So you can see here we have on this axis the condition present, yes or no, and whether or not it's detected by surveillance. So you can think of the sensitivity of the surveillance system as the proportion of all cases that are occurring, which would be A plus C, that are detected by the surveillance system, which is A. So if you have high sensitivity, it means that you're going to miss few cases. It may mean that you're going to detect other things besides the cases as well. That gets to the specificity, but you can improve your sensitivity by broadening your case definition, by encouraging people to report even if they're not confirmed but just suspicious that it may be a case. You can use active surveillance. You can tap into electronic health records. And you can remove barriers to reporting. So making it easier for people to report is going to increase the likelihood that you'll hear about more of the cases that are out there. But the important thing here is that again, it should relate to the goals of your surveillance system. If detecting all cases or a very high proportion of cases is essential to the success of the surveillance system, then you do need to prioritize sensitivity. So you can think of the sensitivity for the individual cases, and as we talked about with the hypothetical measles surveillance system, there was a goal that was also about detecting outbreaks rapidly of measles. And so you can imagine where a system could be maybe not as sensitive for detecting individual cases, but it could be good for detecting outbreaks. And so it's kind of analogous. If you have a surveillance system that's sensitive for outbreaks, it means that you miss few of the outbreaks that actually are occurring there. And you can set the alarm threshold for low if you want to have a very sensitive system for detecting outbreaks. And again, we're adjusting the investment to the importance of that particular attribute for your surveillance system goals. And you can think about positive predictive value of the surveillance system. So in other words, if a case is reported and counted in a surveillance system, what's the likelihood that that case actually represents a true case? So it's the proportion of people identified as cases who actually have the condition under surveillance. So if you have a high positive predictive value in your surveillance system, then most of the reported cases are actually cases. You can achieve this by having a narrower case definition. So this could be a trade-off with the sensitivity and specificity, right? But you can encourage, for example, using clinicians to report only the cases that they know are confirmed as opposed to the suspected ones. And you can have really close, careful review by humans, for example, to make sure that what is being reported does represent a true case. These kinds of things can increase the positive predictive value for cases. And you can have an analogous positive predictive value for detecting outbreaks. So if the surveillance system is telling you that there might be an outbreak, and you know that your surveillance system has high positive predictive value, you can be pretty confident that there's an outbreak actually happening. And there are situations where you want to have negative predictive value for outbreaks as well. Let's take, for example, New York City and many other major cities around the country have Syndromic Surveillance systems, which was really put in place to detect. It's useful for many things, but one of the reasons why it was deployed around the country and in New York City initially was to detect bioterror events, and so attacks that could be a result of deliberate introduction of an infectious disease into a population, and so these systems are sometimes deployed or stepped up during certain events, for example, political conventions in given cities where you think there might be a heightened risk of some kind of bioterror event. And in these situations, you really want to know that you can rely on the surveillance system to say that if it's not detecting something, that you're pretty certain that there's nothing actually happening out there. So that would be a situation where you'd want to have a high negative predictive value. Another important attribute is timeliness. How important is it that you pick up cases under surveillance quickly? And clearly timeliness is something that's more important for infectious diseases than it is for, say, chronic diseases. So we might have a different scale for timeliness when it comes to a surveillance system that's focused on meningococcal meningitis versus cancer. And again, if timeliness is critical for your surveillance system, here are some of the things you're going to want to some of the things you're going to want to do to help ensure that. Active surveillance being one of them, and electronic records and electronic reporting systems really help to that end. So we talked about sensitivity, and it does relate to completeness. This attribute of completeness. So how complete is the case ascertainment? What proportion of reportable cases that come to the attention of those that are expected to report it are actually captured within the system? So I just sort of represent this schematically. If the large circle is all the cases that are occurring out in the population that are under surveillance or intended to be captured by the surveillance system, what proportion are actually reported. And you can see here, you can even further distinguish it. These are the cases that are reported by providers. These are the cases that are reported by labs. And of course, there's some overlap between the two. But you can also begin to get a sense here of how provider and laboratory reporting can not only report complementary kinds of information, but also complement each other in enhancing the completeness of case ascertainment. So it is, unfortunately, with reality, that completeness is almost never 100% and almost never even close to 100%. So, you may have it for some rare diseases of very high public health importance, but in most cases, it's never near 100% complete. And this is an example I like that kind of demonstrates that. So this infection is shigellosis or Shigella, and they're looking for the completeness of what proportion of cases of shigellosis are actually captured in the surveillance system, and to give you a sense of the drop-off and also how long it takes, right? So if you start with all of the cases in the population here, only about 76% of them are going to result in symptoms. And so if there are no symptoms, likely those cases are not going to be detected. And then in only 28% of these situations are symptoms going to be severe enough that people will go consult a healthcare provider. So one point here about surveillance for infectious diseases and almost every other health condition is that many surveillance systems rely on things happening in the healthcare system in order for us to know about them. So if people under surveillance or cases under surveillance aren't touching the healthcare system, it's unlikely, without some kind of community-based approach or survey-based approach, that we'll be able to learn about it. So only about 28% consult a physician or a healthcare provider. A smaller proportion of those actually have, say, a laboratory test done, where they're going to do a culture in this case. And then not all of those cases will be positive, right? There are some situations where the person was a case, but perhaps due to the timing of the test, it wasn't positive, and so the lab wouldn't report it as such. And then a smaller proportion would be reported to the local health department, and so forth. So you can see the big drop-off that happens, and also the amount of time that is elapsed between when each of these different events occur. So those are some attributes of surveillance systems. And next I want to transition to talk a little bit about some of the sources of information for public health surveillance systems. We talked about providers and labs and notifiable diseases and condition reporting, but it's actually the sources of information can be much broader than that. And so we've already talked about a few of these in different points in the course, and you can get a sense of the broad nature of different sources of data, right? So we talked about vital registration, so births and deaths. And that was really important for being able to identify health priorities in populations. We've talked a little bit about morbidity, notifiable diseases, reporting of certain conditions or events. And we set up registries to track these things under surveillance. But there are also some other sources like administrative records and surveys and intersectoral sources of data. But going back to vital registration, this is a decentralized voluntary system that happens across the US. There are actually 57 vital registration jurisdictions, all 50 states, but certain cities, including New York City, is its own independent vital registration jurisdiction, but also 5 territories of the US as well. In New York City, you might remember from the history that we covered few weeks back that they started recording deaths as far back as 1795, and then began compiling continuous death records in 1803 by requiring reporting of burials around the city. And in 1805, the Board of Health was appointed to oversee this registration work. And this gets back to the graph that we showed. So, but what actually happens with death registration in a vital registration jurisdiction? Well, in New York City, we have mandatory death registration. a physician or a medical examiner who attends the death completes part of the death certificate called the confidential or medical part. And then a funeral director completes the part of the death certificates that are called the personal particulars, or the demographics part of the death certificate. And then the funeral director submits the complete certificate to the burial desk at the health department. And this is required to be reported within 24 hours. And this is why the health department is open 24/7, so that these death certificates can be filed on time. And for the most part, all the steps are electronic now, 93% of the time, and there's near 100% complete registration. So it's very unusual for a death to occur in New York City that is not registered as part of this vital registration process. So the treating physician or the medical examiner provides information on the cause of death. The cause of death has 3 attributes to it: the immediate cause, part 1, the sequence of events that lead to that death, which is also part 1, and then other contributing causes on part 2. So to give you a sense of what this looks like, on the electronic screen, the provider would fill out these things here. What was the most recent condition, and which condition led to the above condition, and which condition led to the one before it, and then which is the oldest condition leading to the one above it. And then part 2 includes this other significant condition, so other coexisting contributing conditions, maybe not the direct cause of death, immediate death, but something that contributed to that. So this is the kind of information that is captured on the death certificate that is used to classify the death according to one cause or another. And ultimately what we want to know are both underlying causes and contributing causes. So here's an example of what could be called a well-documented cause of death, right? So they had cardiac tamponade in the half hour immediately prior to death. They had a myocardial infarction in the 8 hours leading up to that. For 15 years, they had atherosclerotic coronary artery disease and high cholesterol over the period of about 30 years contributed to that coronary artery disease. And the other significant conditions contributing to all of this is, in this case, smoking. So this is the kind of information for every death that occurs in New York City each year, and it's about 50,000 or so. The hope is that there is some good information on the death certificate that helps document the true underlying cause of death. And this is the kind of information that can be used to make these kinds of reports that can give you a sense of the major leading causes of death in New York City. So diseases of the heart, followed by cancers and influenza. Ultimately, there are quality control issues, though, and ultimately there are a lot of deaths that occur that are attended by providers that maybe don't know much about the individual person's history, and so a lot of the information on the death certificate can't be filled out as adequately as we might like in order for us to really understand what the underlying causes of death are. But the health department, and sometimes the provider just is not well trained enough in the process of recording this information to do it properly. And so the health department has done a lot of outreach over the last few years to try and improve the quality of the information that gets reported on the death certificate. And we've seen slight changes in the rates and the numbers of death that are not necessarily due to changes in what's happening with the causes of death, but more due to the improvements in the ability of providers to report information on the causes of death. There are some important public health indicators that do not necessarily rely on cause of death and just the fact of death and timing and age of death. For example, the infant mortality rate. There are, you can follow trends in the infant mortality rate, and it really just refers to the age at which the death occurs. You can also estimate things like life expectancy, again, not having really to do anything with the actual cause of death, but more the age of death. And this is an important indicator for public health and the kinds of things that are continuously monitored and updated as a means of keeping tabs on the health of populations. Okay, so notifiable diseases, conditions, and events is also a major source of information for use in public health surveillance systems. And so who decides if a disease is reportable? I think we covered this briefly last week. It's really not the CDC or decided at the federal level. All this stuff happens at the state and local levels in collaboration with or in conjunction with CDC. But ultimately, things are only notifiable by law according to state law and local county or city regulations. So this is who decides if a disease is reportable. So when you look at the national level, for example, in the MMWR, I'm showing here the table that shows reports for meningococcal disease and showing here New York City specifically the number of cases that were reported over time. You can think about this as like, well, where do these surveillance data come from? And it really kind of depends on your vantage point, I think. If you were the CDC at the federal level, you would say these surveillance data come from the state health departments. And if you were from the state health departments, you would say that these surveillance data come from county and local health departments. But if you were at the county and local health departments where the surveillance systems are actually implemented, you would say that, we collect these data, they come from a variety of sources through disease reporting and other surveillance systems that often rely on laboratories and healthcare providers to report that information. So ultimately, all of these national data come from laboratories, healthcare providers and laboratories for notifiable conditions that exist in local jurisdictions around the country. So how many notifiable diseases are they? Also depends on your vantage point. Globally, there are about 25. This is a list that's always changing, as you can imagine, but there's about 25 conditions, notifiable diseases and conditions that are reportable by countries to the WHO on an international level. And at the CDC level, federal level in the US, there's about 91 things listed on their list of notifiable diseases. And if you look at New York State, it's about 75, and there's more in New York City. Actually, local jurisdictions have to do what their state health department and state health regulations say, but they can also do more. And so that's what we're seeing here in New York City. They actually require more things to be reported by healthcare providers and labs than the state does. And one thing to note here, just from an infectious disease standpoint, what about diseases or infections that health departments didn't know about? What if it's a new novel coronavirus or some other new infection that has never really been seen in the world before or has never really been seen in a particular area of the world before and is emerging for the first time? To cover this so that health departments can step in and say, we're requiring providers and laboratories to report information on a particular, say, outbreak that's happening or disease cluster. The health code says that in New York City that providers and labs must report on any unusual disease cluster or suspected outbreak of illness. And this is what allows health departments to step in and require reporting of information even before a disease may be known or has become part of the health code where reporting is required. So you see this clause in there, and that really is there to allow health departments to step up and make reporting requirements for outbreak surveillance so that they can respond to these health threats, even though they may not be listed in the health code. Importantly, Hipaa does not apply to surveillance, even though there is health information that's being shared by providers and laboratories to the health department. It is not a regulation that applies to surveillance. So even you may hear providers state, we can't share that information with you because it's protected under Hipaa. If you're a health department and it's part of the health code that information is reportable, Hipaa does not apply. So here's just a table of reportable conditions and events for New York City, just to give you a sense of how many things and what they actually are. We're going to go into this stuff in some more detail, but there's things that are in Group A, which are very time sensitive and things that the health department wants to hear about right away. And you can see that for these things, they're asking providers to report suspect cases immediately by calling. Do not wait for laboratory confirmation. So again, this is trying to privilege timeliness and sensitivity of the surveillance system because it's important to detect cases early, and these are for outbreaks. Group B also is to report things rapidly, immediately, if the case is a food handler. So this is to protect against potential outbreak situations that could be exposing multiple people in the public. And Group C is where cases are expected to be reported within 24 hours using the online system that the New York City Health Department has created. So how does a provider or lab know what's reportable? What constitutes a case, say, of diphtheria? Or what should the case definition be? Well, it really this depends on the goals of the surveillance system and the available data. So if you think about what some of the possible goals of a surveillance system might be, it might be something like to describe the epidemiology of a disease, the risk factors, exposures, or outcome. But it might be something more related to detecting outbreaks, or something related to primary prevention, where you're trying to prevent the infection trying to prevent the infection from occurring to begin with. Or you're not necessarily trying to prevent infection, but you want to prevent the disease that is related to the infection, or the death that could come as a result of having the infection. So each surveillance system may have specific goals, or should have specific goals, and what you would call a reportable event or a case under that surveillance system will be driven by the goals. And almost every surveillance system for a notifiable condition has something called a case definition. And we're going to go through a few examples of these, but it's really important that they be very explicit. This is what you're going to be asking, in the case of New York City, many thousands of healthcare providers and maybe hundreds of laboratories or laboratorians to respond to, or to follow guidelines to follow. So you need to be very explicit. And it should have certain components in the case definition, person, place, and time, because it's surveillance and epidemiology and public health, but often things related to clinical criteria, laboratory criteria, and sometimes even epidemiological criteria. And you can also consider classifying cases by so-called degree of suspicion. So if it's a confirmed, probable, or suspect case, we saw earlier on the slide, for that Group A conditions and events in New York City, they want reports right away of suspect cases without waiting for laboratory confirmation. The lab data might come later, but they want physicians and providers to pick up the phone and call immediately, even just on suspicion. So you can have in your surveillance system degrees. You can classify your cases according to the information that you have on hand. We'll see some examples of those. So some considerations. Do you need to classify cases according to clinical and exposure information, both clinical and exposure information? So, a lot of reportable diseases and case definitions need both. If you're relying on the medical record or a lab report, the clinical data or the lab test result might be available, but some of the exposure data that we use in epidemiology usually won't be available. So for example, consider some of the exposures that we're interested in around the SARS-CoV-2 pandemic. You may want to know if a person has traveled recently from, say, a hotspot area to New York City, or if they had exposure to a known or confirmed case in the days preceding their disease onset. This kind of information usually isn't available in the medical record, and definitely not on the lab report. So you have to do some investigation in order to get this information. So here's an example of a few. I'm going to go through a few examples of case definitions. This is an example of a case definition for HIV/AIDS in New York City. So first, thinking about the goals, it was about setting up a surveillance system for HIV/AIDS to monitor the epidemic, plan primary and secondary prevention activities, and improve access to care for HIV. And the case definition they used here, seeing some of the classification criteria, any New York City resident, regardless of where they live, regardless of when, a case of HIV is defined as someone whose serum is positive for the antibodies to HIV by certain tests or is detectable in the blood by other kinds of tests. So being very specific about what's meant here. And then they define a case of HIV with AIDS as someone who meets the above case definition for HIV, but also is diagnosed with a number of specific AIDS-defining conditions. And so this you can see that this relates to both primary prevention, new cases, as well as what happens to people with HIV if their disease progresses to AIDS. And this is the kind of thing that the surveillance system generates information to help track that, and presumably, hopefully, information that can be used to act on reducing cases of AIDS and deaths associated with HIV. So another question is, do you need to have information on cases across the entire clinical spectrum? It may be that you can meet your surveillance system objectives only by tracking the more severe cases. And if that's true, you can really simplify your surveillance system. So can you just focus on deaths due to the condition, or people admitted to hospitals, or cases in intensive care units? This requires you to articulate what the goals of the surveillance system are, and then also know and look carefully at the spectrum of disease. We talked earlier, it's really hard for the surveillance system to track asymptomatic individuals who may or may not know that they have a condition or an infection. And then even among those with milder symptoms, they may not even seek healthcare or talk to a healthcare provider about what's going on. So it's very difficult for routine surveillance to track these kinds of cases in the spectrum of infection or disease that is mild or asymptomatic. But it is much easier to identify those cases that are severe, that show up in healthcare providers' offices, in emergency rooms, or are hospitalized. And so you'll often see, as part of the case definition, not every single case of West Nile virus infection that's known, but the more severe cases as a means of tracking, as a means of tracking the infection and achieving the goals of the surveillance system. So in the case of West Nile virus disease, the goals of the surveillance system are to quickly detect human outbreaks of West Nile viral infection, which is a mosquito-borne illness. And you can see the case definition that was used during the outbreak here in 1999. And we're going to go into this case study in more detail later on. But it did specify information on the person, place, time, clinical, and laboratory as well. So what about measles surveillance? And this is a surveillance system that is intended to rapidly identify cases and prevent further spread of measles in the community. And so they have a clinical case definition at the top here that patients or individuals could meet depending on their symptom profile, and then also laboratory criteria to confirm the diagnosis, which includes different kinds of laboratory tests. And here they have a degree of suspicion that classifies cases into suspected, probable, and confirmed. So the suspect cases can be anybody who has some of these febrile illness accompanied by rash, regardless of a laboratory confirmation. A probable case is someone that meets the clinical case definition, again, without laboratory testing and not epidemiologically linked to a confirmed case. And a confirmed case is someone that meets all of these criteria for lab and clinical and epidemiologically linked. So this is an example of a case definition that includes epidemiological exposure information, which must come by definition from field investigation on the part of the health department. So how do providers and labs and other entities report to health departments? Usually they're completing some kind of a structured reporting form, and ideally it's not a single form for each individual notifiable event or condition. So you can use one form to report multiple different events. Increasingly, it's by the internet, but also it's not uncommon to see other modes of reporting, and including an important one, which is directly from the electronic medical records. Laboratories usually submit data files containing reports for multiple events, so that maybe all the tests that were positive in a given day for a bunch of different conditions, if they're a lab that tests across different diseases and conditions. And sometimes there are even other entities involved in reporting, such as pharmacies or emergency medical services. So I mentioned the form, and I mentioned that this is the way that a lot of health departments require providers to report information. And it's ideal if that form is a single form that has multiple different notifiable conditions on it. So that's exactly what the New York City Health Department's Universal Reporting Form is intended to do. I'm going to show you just some screenshots here of what it looks like. It's about 4 pages long, but you can see you can complete it online instead of a hard copy, but it has places for patient information. Importantly, it's getting things related to the date of diagnosis and the date of illness onset, if there was illness. So this is what providers are filling out when they're reporting, a so-called case of disease or another notifiable event. They also capture information on who's completing the form, who's reporting the case, and they get from the providers the name of any testing laboratory that was used where they may have sent specimens. Here you can see this, how they're sort of operationalizing this clause of calling health department if there's an outbreak or suspected outbreak of any disease or condition of known or unknown etiology, which may be a danger to public health. So this is also that situation is something that providers are required to report to the health department about. So moving into some of the different diseases, you can get a sense here where you can find, it's in alphabetical order, of the particular disease that you may, or condition or event that you may be reporting. Meningitis is here, and also giardiasis, a parasitic disease, animal bites. So again, just to remind you that it's not just infectious diseases that are something that are notifiable and under surveillance in New York City. Going on to other pages, and here you can see another example. Window falls is reportable in New York City. HIV/AIDS is one exception because of state regulations and around protecting privacy and confidentiality. There is a separate reporting process for HIV and AIDS that providers use. They don't use the universal reporting form for HIV in New York. Poisonings are also reportable on this form, and this is the section for poisonings. And there's an entire section that is related to sexually transmitted infections. And here they are trying to get some epidemiological information from the providers. Well, not so much epi information, but did they provide treatment for any of the patient's sex partners in addition to the patient themselves? And here's an entire section for tuberculosis. And now I'm showing you an example of a laboratory requisition form. So this is a form that a healthcare provider would fill out if they were ordering a lab test on a patient, for example, to test them for HIV or to test them for a particular infection like Lyme disease that may be reportable. And what you can see, I guess what I want to mainly call your attention to here is that it's pretty sparse in terms of the amount of information it collects. And only these fields highlighted in red for this particular laboratory are required, right? So, the sex and date of birth information is required. Billing information is required, not surprisingly. The date that the specimen is collected, and of course, which test is being ordered. And so this is like the minimum amount of information that a laboratory might have to report to a health department when the test result comes back. And so just to point out here that while it has very valuable information on a diagnosis, It may not have much useful in the way of epidemiological information or even demographic information. For example, race ethnicity is completely missing from here. Zip code of residence may not be there at all. So just to keep in mind, laboratory reporting is not a substitute for provider reporting, where you can get more detailed information on the clinical history and sociodemographics of the individual. So you can think about, provider and laboratory reporting in terms of the attributes of surveillance systems that we covered before. They're both passive means of getting information, and you can see the kinds of information that you might get. From providers, you get detailed information on demographics and date of birth and clinical information on symptoms. You may or may not get information on lab test results. They may be not back from the lab by the time the provider is reporting. There may not be any lab tests. And then you may or may not get information on exposures. That's also something that, health departments usually, if they need it for surveillance, they usually end up having to get it themselves. And reports are per diagnosis, so usually one report per patient per provider. For laboratory reporting, you get that sparse information that I mentioned, some basic identifying information, the lab test results, and reports are per test. So you may have, just from a data management standpoint and understanding the data you're getting, there may be multiple lab reports for a single individual in the reports coming from labs. And you can complement this or even replace provider reporting and lab reporting with something that's more active surveillance. But usually it's some combination of these three things. Usually it's passive, and sometimes where there are resources available or where the goals of the surveillance system dictates it, active surveillance is a key part of the system. And from these notifiable diseases, conditions, and events, health departments often create registries which can be used to support surveillance. And so examples of these, we've seen some. Vital registration of births and deaths are examples of registries, but there can also be registries that are specific for diseases or conditions. For example, there's an HIV registry, a TB registry, where every case that is reported by providers and labs or ascertained through active surveillance on the part of the health department is maintained on that registry in perpetuity. And so it's possible to follow the outcomes over time. Also, there are registries for people who receive immunizations. So the city keeps a record of all childhood immunizations, and it's called an immunization registry. There can also be case series and hospital-based registries for specific diseases and health outcomes. And there can be registries that are mainly based on an exposure. I mean, immunization is an example of that, but there's also a World Trade Center registry, and it's a registry of individuals who were exposed through their proximity to the World Trade Center attacks on 9/11 here in New York City. It includes a lot of people who were exposed occupationally, but also people who were there at the immediate aftermath of the attack. But these registries can all serve as the basis for a surveillance system, or they can complement one. Just to show you here, you can go to the city website and see some of the data that comes from these surveillance systems and registries. It's a system called EpiQuery. I'm going to try to get us there now so you can get a sense of what it looks like. So you can go into the disease reporting and look at the communicable disease surveillance data, for example, here. It's very crude and simple. There's not much in the way of slicing and dicing the data that you can do, but you can see for all the different reportable conditions, you can get a sense of how many cases, communicable disease cases, have been reported over time here in New York City. So that's EpiQuery. Okay, so in addition to vital registration and notifiable disease reporting, there's also administrative sources which can be important for conducting surveillance. So what are these? These are data that are not set up for the purposes of public health surveillance. They're set up for other purposes, such as billing systems or keeping track of who's admitted to the hospital, and laboratory information systems, or healthcare claims data and pharmacy sales data. These systems exist because they need to exist in order to support the activities of, say, an emergency room or a pharmacy or a health insurance company, but they can be made available and used for the purposes of public health surveillance as well. And so that's what we mean by administrative data collection systems. They're usually in place for other purposes, but they can be useful for surveillance. So here are some examples. The Medicare data, and the Medicaid data, which are healthcare claims data, or there's a United States renal data system that tracks kidney disease-related outcomes. There's the Healthcare Cost and Utilization Project, the National Healthcare Surveys, and then state-based hospital discharge data. For example, New York State maintains a database called SPARCS that includes information on every single hospitalization that occurs in New York State every year, and a lot of information related to the diagnoses and procedures that took place during the hospitalization, which can be very useful. And here's an example of the kinds of things you can do with hospital discharge data. You can look at the rate of hospitalizations for something like diabetes, a very common condition that also is something that is associated with a lot of morbidity and mortality. And so it's important to be able to monitor what's going on with diabetes in the population, not just new onset diabetes, but some of the bad outcomes of having diabetes. It is one of those things that if there is good access to care and access to treatment, there should be a manageable level of morbidity, and hospitalization should be avoided. So when you see increases over time in the diabetes hospitalization rate, this is something that a surveillance system can tell you that is flagging for health departments that they need to look into some of the drivers. This could be happening because the prevalence of diabetes itself is going up, or it could be happening because there are some access to care or quality of care issues that health departments need to look into. Another important source of information for public health surveillance is surveys. So these are the kinds of things that can be useful when you can't get the information you need from activities that are happening in the healthcare system or that are information generated by laboratories. So these are useful for really assessing prevalence of health conditions and also in the population, and also risk factors. And you can conduct surveys repeatedly over time to monitor changes in prevalence. And importantly, you can also assess things like knowledge, attitudes, and practices around specific health conditions or across a range of things. What do we mean by surveys? Here's some examples. The National Health Interview Surveys, the Behavioral Risk Factor Surveillance System, Youth Risk Factor Behavior System, and the Community Health Survey in New York City. And there can also be provider-based surveys. These interview surveys are mostly phone-based surveys, but you can have surveys that are exam-based surveys where the individuals are seen in person, they're examined by a healthcare provider, and there may be some laboratory tests or other kinds of tests that are done, such as an eye exam or blood pressure measurements and things like that. So as you can imagine, these provide useful population-based data on not just health conditions, but risk factors. And this is an example of a report from New York City that used some of their survey data to measure the prevalence of smoking, current smoking, and breaking it out by different factors. The two bars are showing prevalence differences by sex, but they are also looking at things related to some of the initiatives that the health department was trying to push forward, such as the proportion of people that tried to quit, the proportion of people that were heavy smokers, and a proportion of people who purchased their cigarettes in a store. Another important thing that you can measure with surveys that you can't really measure by looking in the healthcare system or in labs is the extent to which people, are not getting medical care when they need it, right? Those folks are not going to show up in the healthcare system. And so you can ask about questions like, was there ever a time in the last year that you needed healthcare but didn't receive it? And do you have a personal doctor? And then you can stratify that information by insurance status. And what this slide is showing that you're much more likely to go without needed care when you need it if you don't have health insurance coverage or if you have public insurance. And similarly, in terms of having a personal doctor. Very useful information for health departments to have so that they can address or at least highlight problems around access to care. And here's an example of the exam survey. There was a survey done, a health and nutrition examination survey done in New York City several years back that also examined patients, examined individuals, and took blood specimens, and they were able to estimate the prevalence of herpes virus type 2. It's not something that is reportable in New York City, so they wouldn't be able to get this kind of information. It also can be asymptomatic, so it would not be easy to track the whole spectrum of herpes virus type 2 infection through, say, laboratory reporting or provider reporting. But through through a survey that includes an exam and a specimen collection, they were able to show that the overall prevalence of this particular infection was between 25 and 30%, and that there were big sex differences. So again, useful information for monitoring the burden of diseases and exposures and risk factors. Lastly, there are some data sources that are outside of the healthcare system, outside of the healthcare sector, that can be useful for public health surveillance. And so what are some examples of these, right? Census data, that's something we use all the time in public health. It's not collected for the purposes of public health. There's also data sources out there that provide information on tobacco sales or monitoring the purity of heroin, which is useful for understanding trends in overdoses and overdose deaths. Gun sales, ozone levels, air quality, and also weather and climate-related data. All these related to health outcomes. They're collected and maintained, data sources that are collected and maintained outside the healthcare sector. But I like this example that shows blood lead measurements that were collected as part of a survey, NHANES, shown here in red, the declines of blood lead levels that occurred in the population over time from the NHANES surveys, but then correlated it with some other data which was outside the healthcare sector that measured the levels of lead in gasoline. There were major efforts to remove lead from gasoline phased in over a period of time. And this analysis showed, using this sort of data from other sectors, that the declines in blood lead in humans was tracked very closely with removal of gasoline from lead. And of course, this evaluated and supported the policy decisions to move to unleaded gasoline for the health of the human population. So just to wrap up, surveillance systems often rely on multiple, sometimes redundant sources of information, right? At most basic, we see in notifiable diseases that are reportable both by providers and also by labs. That redundancy helps to ensure that a more comprehensive picture of what's going on, so they have complementary kinds of information, but it also helps to bolster the completeness. You may have situations where you don't hear about a case of a given disease from a provider, but you do hear about it from the lab, and that can prompt an investigation on the part of the health department to find the provider, get the clinical information, and sort of complete the case report. So these two systems together, or these two sources together, can really bolster completeness and comprehensiveness of the surveillance system. We also saw, and I want you to take away, that surveillance systems are not always based on notifiable events, though for infectious diseases, this is often the rule. They can be based on all kinds of other data sources. We saw the multiple sources that can be used for surveillance. And surveys can be useful for non-notifiable conditions and even infectious conditions. And they are especially useful for getting information about risk factors and behaviors and healthcare access. But surveillance systems often have limitations around things like timeliness and completeness and accuracy. And so for for these surveillance systems to be most useful, and they really can be mission critical and extremely useful to achieve public health goals, you really need to understand the limitations of every surveillance system and try to understand how those limitations may or may not hinder the achievement of the surveillance system goals and the public health goals that the surveillance system is intended to support. So I'll just wrap up here before we just talk a little bit about surveillance for SARS-CoV-2 in New York City. This is a quote from Alex Langmuir, who is considered the father of the field of public health surveillance, who said, good surveillance does not necessarily ensure the making of the right decisions, but it reduces the chance of making the wrong ones. And this acknowledging something basic about public health surveillance, which is it's more of an art than a science. It's never perfect, but it is something that can be extremely useful, and it is possible to do it well and support the goals of public health practice in the process.
Okay, so just wanted to spend a little bit of time at the end of this session on surveillance, public health surveillance in our ID-EPI course to talk about surveillance and metrics for SARS-CoV-2 in New York City. And just to lead into that with a little bit of a overview of a commentary that a colleague of mine and I wrote in AJPH last spring entitled Goal-Aligned Epidemic Intelligence for the Public Health Response to the COVID-19 Pandemic. What we were really trying to get at in this commentary was at the importance of relying on metrics that are goal-aligned with the public health response to the pandemic, and also importantly disseminating those metrics in as timely a manner as possible to all those who need to know. So this relates directly to this concept of surveillance as we have defined it, right? The ongoing systematic collection, analysis, interpretation, and importantly, dissemination of health-related data essential to the planning, implementation, and evaluation of public health practice. And that's really what this is when the rubber meets the road, is the response to the SARS-CoV-2 pandemic. So the emergence of a novel coronavirus in January or February of 2020 in the US is an example of one of those situations where SARS-CoV-2 obviously was novel and was not on a list of any reportable diseases. So there was no surveillance system in place, no standard case definition, no diagnostic test, et cetera. But those needed to be developed and deployed quickly because an effective public health response to the epidemic really requires a nimble and intensive and effective public health action to minimize spread, suffering, and deaths, as well as the socioeconomic and racial inequities in these outcomes that we've seen. But also an effective response to a situation like this pandemic requires good surveillance data, or what we refer to in this commentary as epidemic intelligence. So good intel on your epidemic so you know where it is and where it's going so you can respond accordingly. However, what we were concerned about and what we have seen in the past is that sometimes this kind of thing is neglected in emergency responses. This idea of systematic gathering and timely dissemination of data and information and intelligence on your epidemic, especially with regard to a well-aligned set of metrics that are closely aligned with the goals of the response. This was something that was concerning to us very early on. We certainly didn't see it federally, and in some places it wasn't clear that it was even happening at state and local levels. And so we decided to sort of write a commentary to sort of make some of these points. But in order to have some metrics that are aligned with the public health response goals, right, you need to have clearly articulated goals of the public health response. And we didn't think this really existed early on, or at least they weren't stated explicitly by agencies like the CDC or health departments around the country. And so this was another reason we thought it was important to write this piece. So we articulated what we felt were like three key goals. Of course, there are many goals, right, to the public health response of the SARS-CoV-2 pandemic. The first one we put out there was to mitigate, suppress, and control community transmission of the virus through physical distancing and other non-pharmaceutical interventions. There's no vaccine, there's no treatments. And so really the only tools that we had from a public health standpoint is non-pharmaceutical interventions. Goal 2 was to, after trying to control community transmission, to prevent or minimize morbidity and mortality from COVID-19 disease. And the last goal that we put out there was to protect the healthcare workforce and other essential workers from becoming infected with SARS-CoV-2. So we sort of set this up as the three goals, as at least three key goals to the public health response of the SARS-CoV-2 pandemic that we thought were important. And then we went through the process of thinking, okay, well, if these were the goals, what are some of the important metrics? And that would, of course, drive some of the surveillance goals that health departments might move forward. So thinking about this goal by goal, right? For community transmission, you really need a time updated proxy for incidence of infection in the general population. It's not something you can measure, especially when there's a lot of asymptomatic infection or people who are not sick enough that it drives them into the healthcare system where they can be tested. By the way, there was no test or not a test not really available early on, and so we had to think about things where how to do this where the testing capacity is limited or changing rapidly. Looking just at positive tests when it wasn't really widely available could be a poor reflection of trends in transmission and spread. And so we made the point that tracking COVID-related hospitalizations and deaths that were due to COVID in an area, in the absence of good testing data and good incidence data, you could monitor hospitalizations and deaths to infer what was happening with trends in SARS-CoV-2 transmission 5 to 15 days earlier, right, because of the incubation period. So if we look at what's going on with hospitalizations today, and trends in hospitalizations, it reflects what was happening with incidence of the infection in the population sometime earlier. It's not ideal, it's not as timely as we would like, but it's still, better than nothing. And in fact, the New York City Health Department has a really good system in place to monitor these kinds of things called syndromic surveillance. They monitor trends in department admissions for influenza-like illness and pneumonia, which is not the only way that SARS-CoV-2 presents, but it is one major way. And you can see here, like if you're looking at the trends in emergency department visits on the top here, and emergency and admissions to the hospital from the emergency department on the bottom, you can see in red, this is showing the flu epidemic for last season, and then subsequently the rise in emergency department visits that happened as a result of SARS-CoV-2 spreading in New York City. And that's emergency department visits, and down here what we're seeing are actual hospitalizations. So these are severe cases of SARS-CoV-2. And what's happening here is reflecting what was going on with SARS-CoV-2 transmission and incidence, some days earlier, but still very timely. These data come out every day, and they're up to date, and the health department puts them out on the web pretty quickly, like the next day, so that people can keep an eye on the trends. They also publish information on all of the hospitalizations in the city, not just those that were relying on syndromic surveillance or coming in through the emergency department, but any hospitalization really. And also they were reporting on the number of deaths over time. So as you can imagine, these are surveillance systems, and these are the kinds of surveillance systems that the city put in place to be able to monitor what was going on with the spread of SARS-CoV-2. So goal two, preventing or minimizing morbidity and mortality from COVID-19 disease. So this is about, and you maybe remember early on, there was a lot of concern about overwhelming the healthcare system and the surge of hospitalizations that could result, and that when the hospital system becomes overwhelmed, that there would be even more deaths because of the lack of capacity to take care of the many individuals who could be sick at levels of surge that were expected. And so for this, metrics like looking at the daily number of people in critical care across health and hospitals is one of the metrics that New York City put in place. And we also thought that it was important to be looking at nursing homes and some of the outbreaks that were happening there. And so tracking the number of outbreaks in congregate settings. In nursing homes, a very large proportion of all of the deaths in New York State, and I think an even larger proportion of all the COVID deaths across the country occurred in nursing home residents. So something like 30% in New York State, and maybe 40 and sometimes 40% and sometimes even higher in other states around the country. This is just a table I looked at several months ago about outbreaks, nursing home outbreaks in Connecticut, which is a state that did publish the number of residents that had COVID-19 and also the COVID-19 associated deaths. And I looked across all the nursing homes, and in this case, there were about 1,700 cases at the time. Among 375 of those cases, there were deaths. So that was a case fatality rate of about 22%. So this is very high, and it reflects the vulnerability of nursing homes. And so thinking about metrics for preventing COVID-19 deaths, which was our second public health goal here, you really do need to focus on congregate settings and nursing homes and those populations that are most vulnerable. And goal number 3, protecting the healthcare workforce and other essential workers from becoming infected with SARS-CoV-2. We really thought that we really wanted to say here that public health had to prioritize the tracking of health screening and testing of all frontline healthcare workers and first responders, and tracking their absenteeism and deaths. And so we listed a number of metrics here, and I include here some data from an MMWR that looked at what was going on with SARS-CoV-2 case surveillance more broadly around the US, that found that of the 315,000 cases reported to the CDC through April 9th, about 16% had some information on healthcare worker status. And of those, they looked at the case reports, and about 11% of them were among healthcare workers. So this was, not surprisingly, because they were seeing some of the first COVID patients and not having enough personal protective equipment to protect themselves and to prevent infection from spreading within the healthcare setting. There were cases in healthcare workers, and they were severe in many instances. So they showed another table here with about 723 hospitalizations occurring, including ICU admission and death. So to really have an effective public health response that prevents community transmission and prevents morbidity and mortality, we need to make sure that our healthcare workers and frontline workers and essential first responders and essential workers are protected. And this is something I hope we do a better job of the next time around. And we also sort of closed with putting out some ideas about how there should be metrics that guide the reopening of society. So when is it safe to begin to think about opening society up and loosening some of the restrictions? And importantly, when things got to a certain place where they felt less safe or transmission was ramping up, specifying thresholds when restrictions would be reenacted. We didn't say what those thresholds should be or what those metrics should be, but we did sort of make a point of saying that they should be specified a priori. And this is to sort of get out of this realm of decisions being made about public health that are sort of politicized and being subject to the local pressures that are of the moment. And while it may be unrealistic in some settings around the country, we just thought it was important to specify the ideal here, which is that thresholds for opening and closing things should be specified a priori, and they should be informed by public health experts. So some examples of some of the metrics that New York State and New York City were using are listed here. A 14-day decline in virus-related hospitals or deaths, or fewer than 5 a day averaged over 3 days, would allow certain areas of New York to move forward to different stages of their reopening process. For the latest trends, you can go to the city website for their latest data on their COVID-19 data page shown on the left here. And for national data and metrics, you can go to the CDC's COVID data tracker. The metrics that have been used have evolved so much since the beginning of the pandemic, and now include things like vaccinations and boosters and other things like that. So there's really so much important data and information to track around the COVID-19 pandemic. It's constantly evolving, so making surveillance more complex and data sources, data streams, the number of data streams increasing. I will say that one thing that's important about the public health impact of the COVID-19 pandemic to date that is not really well reflected in any of the metrics, either at the CDC federal level or in any of the states, is this issue of long haul COVID. It's a sort of long-term sequela that happens to about 20 or 30% of people who get COVID-19 infection, not just severe cases, but also some mild cases. And it can be really quite debilitating. And this is, I think, one of the legacies of the COVID-19 pandemic that we're still learning a lot about and is going to be with us for quite some time. And many of us are pushing for a new surveillance system that does track this issue of long COVID a little more systematically and including some top line national metrics. So that's, I think, some of the latest that's happening in the COVID-19 pandemic realm for the issue of surveillance. And we're going to have a bit more on COVID later on in the semester when Saba Kasmia is going to present some of our latest work on COVID that we're doing here at CUNY.